First of all, I would like to thank my panelists for joining me for the session. The more proactive it is, the best it is. As Viraj has told you, metastatic pancreatic cancer has a very, very poor outcome. And compared to the West, it has a relatively lower incidence in India. That is 0.5 to 2.4 per lakh men and 1.2 to 1.8. 24th in the list. But the unfortunate part, which all of us know, is that about 20% of patients are resectable. So this is a typical case, Vineet. You have a 60-year-old male, hypertensive and diabetic, no significant family history, ECOG PS1, had a pancreatic mass, multiple liver as well, and biopsy is adenocarcinoma. So let me ask Piyush, any way you can predict the prognosis upfront in these patients?
So, sir, a performance status of albumin, a performance status, nutritional status, presence of ascites or absence of ascites. Probably these are some factors which we look at clinically. So this would help us in optimizing our drug dose density and choosing our drug.
So how often do you use it in your clinical practice? Do you use it or?
The particular score or right now on the screen, sir, I just read once you sent the slide set yesterday. Okay. But otherwise, this is what we use.
Okay. So generally, to be very frank, I also don't use it verbatim, but then few of the pointers in this, especially the albumin, the performance status, all these come into role when we go about treating these patients. So going forward, if you talk of molecular testing, Mudashir, what would come into mind when you start doing the molecular testing in these patients? And how would you rank it on a scale of 1 to 10, or rather 1 to 5? How would you proceed?
Hello, sir.
Yeah, Mudashir.
Sir, I think molecular testing has become now very important because of many things. One is the selection of the chemotherapy, as well as the selection of the the option of maintenance therapy in metastatic setting. So BRCA1 and 2, as well as PAL-B2, and if possible, the rest of the HRR panel, and MSI. I think these will be very important, in the first line setting to decide whether to go for any further after the initial response to the chemotherapy.
Right. So you would put BRCA1 and 2 as the first test to be done. But Shruti, all of us know that only 5 to 7% of pancreatic patients have a germline pattern. And that is what is the testing which we are doing according to the Polo trial, because that was only for the germline patients. 40 patients are there who are germline BRCA1 and 2 mutation carriers who do not have a family history. So which are the patients would come into the ambit of getting the BRCA testing? Would you include all of them, or would you, any specific subset would you go to? Any thoughts?
No, sir. With the availability of an agent like Lynparza for these patients, I would want to test everyone for germline BRCA1 and 2 mutation.
What about somatic?
And that would actually spare. I would want to do the germline test first, and suppose if the germline testing is negative, then I would want to offer a broad panel NGS, including all the other mutations, KRAS, BRCA, HER2, and all that, because that will be done on the block. And
so
yes, sir. So germline first.
Germline first, and then somatic, and then probably you would go for the others. So you have a host of mutations which are there. You have actionable mutations, but the problem in pancreas is that it has a very low immunogenicity, unlike the other tumors, and a non-inflamed phenotype, and that stops us from going straight away to using immunotherapy in pancreas unless you have the MSI. So that is why now the accent is to add it to other drugs like vaccines or chemotherapy or targeted drugs so that you can get the maximum benefit. Anita, you have these approaches which are liable to only less than 1% of patients. So how many of them do you do in your general practice, in your clinical practice as of now? Dr. Anita. Is Dr. Anita there? Well, if Dr. Anita is not there, can I ask Bharat? Bharat, can you tell us?
Yes, so for pancreatic cancer, sir, the biggest problem is not to get those mutations. And as you know, in most of my patients, we go ahead with the standard first-line therapy in a fit patient FOLFIRINOX. I go ahead with all these investigation only when no patient tends to finish off all the standard lines available.
Yeah.
Except germline BRCA, I don't try to get all these NGS panels unless some patient is very keen with all those accessibility to the treatment in terms of the financial.
You know, what I meant to say was, given on a scale of 100, what would be the percentage of patients whom you would be subjecting to these upfront?
3 to 5%, sir. Not more than that for pancreatic cancer.
Piyush, what do you think?
Yes, sir. With the sort of expectation with MSI or KRAS, I think so. It's a single digit.
Single digit. Mudashir, any change?
No, sir. I agree, sir. It is very small number of patients. But the only thing is, sir, sometimes this MSI may indicate a germline loss. That is, it may indicate a HNPCC. So that is kind of very.
That is fair enough. But just wanted to know the percentage. So we all agree that in our clinical practice, not more than 5% times we go and do these tests. So coming to you again, Bharat, the testing methods, which one would you prefer when you go about testing? Shruti told that you do germline first and then you do somatic. So given a choice, which one would you prefer?
So based on the recommendation, I would like to do germline testing.
Yeah.
Beyond that, if again, I would like to go for some rare things like NTRK, HER2, then definitely I would have a broad NGS panel. When the patient is fit and already exhausted with all the treatments and really there is no chemotherapy arm, then I would really go behind all these biomarkers, at least to search for a rare thing, something like.
So for germline, would you go for blood or would you go for the tumor tissue?
No, sir. For germline, the blood.
But Shruti, what do you think about cell-free DNA testing? What is the current status?
So for the cell-free DNA testing, it's very important to check that the lab which is doing the testing, what is the sensitivity. Also depends on the metastatic burden. I mean, how much of the tumor is being shed into the blood would determine whether we can pick a cell-free DNA on the test. Otherwise, the test would just turn negative. So I think that in India there are many labs with where the sensitivity issues would be there. So I would be a little hesitant on doing that.
Yeah. Standardization is a big problem. I agree with you.
Yes, sir.
So having said that, I think doing a germline testing, blood would be the easiest. Is that okay?
Yes, sir. Yes, sir.
Fine. So coming to the chemotherapy protocols, gemcitabine established treatment standard over 20 years where it was pitted against FIFU. Then you came with the gem-nab-paclitaxel, which also showed that there was a PFS and a survival benefit. Following that, you had the FOLFIRINOX and you had the modified FOLFIRINOX, which showed that had a benefit against the current standard, which was gemcitabine. So you have these three drugs, and in our clinical practice, as all of us see, we keep on fiddling between any one of these protocols depending upon the various situations. So I would like to put across certain situations and see how we can come to a consensus. So if you have a young and a fit patient, the management in first line metastatic pancreatic cancer, which one would be your option? Dr. Anita, are you there? I can see Anita, but she's muted. Okay, if Anita is not there, Dr. Rajesh is there. Rajesh again is not there. So let us ask Dr. Mudashir. Young fit patient. What would be your choice?
For young fit patient, I would go for modified FOLFIRINOX since it has shown overall survival advantage with respect to the gemcitabine alone. So I would go for this.
Piyush, any change, or would you agree with the same?
No, I agree with Dr. Mudasir.
So young fit patient, definitely you would go for the best PFS and the OS benefit. Now, the flip side is you have an elderly patient. Shruti, what would you like to do in this case? You have again these choices. You have a triplet, you have a doublet, you have another modified doublet, and then you have a single one. So what would you choose amongst these patients? Dr. Shruti, are you there?
Sir, is the question for me, sir? Yes, sir. So for an elderly patient, I would want to opt for gemcitabine based chemo, gem plus nab-pacli, because it is better than gem alone. If the patient is very, very frail, then I would want to use gem carbo or gem alone. So.
Okay. So let me ask Bharat. Bharat, here, would you check for the comorbidities, or you would just go on the age and you decide a protocol here?
No, sir. I would not go on the age as an elderly, because in pancreatic cancer, we have a limited options and we have to sequence them very properly. So geriatric assessment is very, very important for elderly patients.
Yeah.
We can't just look at the age. And we have a fraction of patients who are fit. In them, I would like to go ahead with FOLFIRINOX, because I do understand subsequently these patients may not be able to take this regimen. So for those subset, I would like to start with FOLFIRINOX, FOLFIRINOX, and then subsequently gemcitabine. But yes, even there are young patients who may not be able to take this stronger regimen. Sometimes we have to go beyond dose modifications and modify your doses. We have to make sure that the patient receives both the lines of treatment. That should be the aim.
Yeah, so there is a slight difference. Bharat feels that patient should get the best bet if it is a fit elderly. So you have a fit elderly, you have an unfit elderly, you have an elderly with comorbids. Piyush, any change in your line of management, or would you agree with Bharat?
No, I largely agree, sir, that in a young individual, definitely is FOLFIRINOX, but elderly, we tend to consider gem nab-pacli, but of course, if we look into all the comorbidities, no neuropathy, active 70-year-old also, we have given modified FOLFIRINOX, so that is also an option.
Shruti, you mentioned
wherever if we can position modified FOLFIRINOX first, it would be.
Wherever possible, you give the best bet. Shruti, you mentioned gem cis in this category. Any special reason why you said gem cis versus gem nab-pacli?
No.
I think we are having some.
I think she mentioned
assumed that
gem
its patient is
gem carbo. Yeah, gem carbo.
Gem carbo I had mentioned. Yes, sir.
Okay, that's fair.
Yes, sir. But
So,
my preference, if I'm not choosing a triplet, I would want to use a doublet.
Sure, absolutely. So the third one is again, which we come across in our patients with the pancreatic cancer, deranged LFTs. So you sometimes have surgical obstructive jaundice, sometimes you have parenchymal jaundice, sometimes you have transaminitis, sometimes you have a combination of both, sometimes you have a biliary leak or a biliary block or a cholangitis. So all these things rummage around to cause deranged liver function tests. So Mudashir, your patient with deranged LFTs, let's say the patient has transaminitis of say 400. What would you like to use? and what precautions you take?
Sir, in such a patient, I would first see that if the LFTs are deranged because of the obstructive jaundice. So obviously, it goes without saying that we will try to address that problem. In addition to that, sir, my choice of chemotherapy will differ because I would be avoiding the gemcitabine and paclitaxel in such a patient, and I would probably go for, if the bilirubin is less than 2.5, would go for a we may still try the gemcitabine if it is less than 2.5, but more than 2.5 or any derangement of the LFTs, then I would go for a FOLFOX type of regimen.
But FOLFOX again would be very, very hepatotoxic.
But with very close monitoring, sir.
Close monitoring. Bharat, what would be your choice? How would you go
So
about?
if deranged LFT is not because of something obstructing, we do come across because of extensive liver metastasis, and usually these patients are going to do badly. So something we start with a single agent and subsequently add the another agent. So I would start with single agent gem and subsequently would like to add cisplatin.
So you would have a cautious approach. You start with a singlet and you proceed up. Piyush, what would you do?
Yes, I agree that if in case it's because of a hepatic parenchyma damage, then of course it's a poor prognosticator and such patients would have low albumin and then probably single agent therapy. Otherwise, if it's a obstructive component, as Mudassir pointed out, correct that, and then probably FOLFOX there also, I can consider FOLFOX. Even I have given less than 5 or 6. I have considered FOLFOX and even GemCis for that matter.
Yeah, Shruti, what would you do? Shruti is, I think, not able to respond. Anyhow, I think so. I think we have a broad consensus. If you have surgical obstructive jaundice, you relieve the jaundice, and then probably you can go to a doublet. If you have a poor PS patient, you start with a cautious approach, give a singlet, and then go up with a doublet. If you have a really fit patient who just has minimal comorbidity, then probably you can again hazard a doublet. The basic accent would be preservation of the quality of life in these patients. Now coming to the new kid on the block, the patient is BRCA mutation positive. So now Mudassir, any change or you would follow the same upfront?
Sir, BRCA mutation positive, since we know that, the platinum, I would like to use platinum in such patients. So FOLFIRINOX.
You have a choice between oxaliplatin and cisplatin. Which one would you like to prefer?
Sir, because my preferred agent in the pancreatic cancer metastatic is always a modified FOLFIRINOX, unless there is a something which will not allow me to use modified FOLFIRINOX. For example, elderly and sometimes very sick patients.
So you would prefer a platinum regimen, platinum-based regimen in this.
Correct, sir.
You,
So
please. Yeah.
I may start with some FOLFOX and then later on add irinotecan if the patient is, I feel that.
Piyush?
I agree with Mudassir sir that any of the platinum agents, probably cisplatin or oxaliplatin, but since we are using FOLFIRINOX quite frequently now in pancreatic, so FOLFIRINOX is.
So in your practice, are you using FOLFIRINOX or are you using modified FOLFIRINOX?
Modified FOLFIRINOX.
So all of us are using, I think, modified FOLFIRINOX nowadays. So BRCA mutation negative, Bharat, how do you go about? Dr. Bharat there?
Yeah, so standard approach again, what we discussed so far, fit patient, modified FOLFIRINOX, those who can't take it, gem nab package.
Okay. So any other thoughts? Shruti, are you there?
Yes, sir. Sir,
Yeah.
I'm sorry, I was lost in between. Sir, for a negative patient, I would, for a very, very fit patient, I would prefer to use FOLFIRINOX, and otherwise I would offer Gem-Nab-Pacli. Even if the patient is negative, a triplet would give a better response in a young fit patient. That is what I feel.
Sure. So now you won't focus on the platinum, you would focus on the DFS and the OS if fitness is not a problem in these patients. Fair enough. So
Yes, sir.
what if the mutations are unknown? Then again, would it be the same or would you change? I can see Anita now. Anita?
Yes, yes. Sorry,
Good evening.
Vineet, was in the OPD. Yeah. I'm still not finished yet. Okay. Yes, if the mutations are unknown, yes, in a fit patient, good performance status, not much of comorbidity, I will prefer the 3-drug regime. Okay, we are giving it, and also we see whether I'm in the medical college or in the corporate side. Yes, FOLFIRINOX would be my choice.
Right. So I think we broadly agree that the performance status, the lab parameters, LFTs, age of the patient, and comorbidities, they play a very important role, and also the BRCA status. So these are the 5 or 6 issues which are clinically there whenever you take a choice of regimens in these drugs. And 4 to 9% of the metastatic pancreatic patients may harbor these mutations. All of us know, and this was seen in this study, which was the registration trial, that is the Polo study, in which Viraj has eloquently told the 23% of patients had a combined CR and PR with a median duration of response of 2 years, which was practically unheard of earlier as far as pancreatic cancer patients were there. But of course, every study has its own criticism, its own pitfalls, and its own drawbacks. So, Mudashir, what do you think about the drawbacks of these trial, the Polo trial?
Sir, one drawback was that in spite of, actually you have pointed out, sir, in spite of no crossover, we always blame overall survival, no advantage of overall survival, we blame it on crossover.
Exactly.
But here there was no crossover and still no overall survival. So
Exactly.
that.
And of course, patient selection, only germline mutations, and 10% of the patients who received placebo after the initial period were still progression-free after 2 years. So how do you explain that? Age factor and doubtful efficacy, 1 year PFS lower in the treatment arm. So you have a patient subgroup which is in the placebo, which is still doing well. You have another one which even after treatment is not doing that well. Cost, toxicities, of course, in the Indian scenario, that hold a very important facet there. Now, if you talk of only PARP inhibitors, what about chemo plus PARP inhibitors? Dr. Anita, any thoughts?
Yes, I have actually used for 2 of my patients where we have a couple of studies, like rightly you are putting up, when there is a mutation and with the use of cisplatin, exactly the same cisplatin and gemcitabine I have used with the PARP inhibitors. Yeah, but the data is very early data. Their responses are shown, but again, yes, you can explore, because now
So
combination treatment is going to be the
right. This is in the pipeline. So probably I think in times to come, we should be more. Anybody? Anything? Okay. So coming to the maintenance therapy, which Viraj has already told. So you have maintenance with the PARP inhibitors, and then you have a trial which is known as the Pan-Optimox study, something like the Optimox trial. Here you have 3 arms. One is standard 12 cycles of FOLFIRINOX. The third one is in which it is Furgen, that you give alternate FOLFIRI with gemcitabine, and the second one is the interesting one in which you give 8 cycles followed by 5-fluorouracil, and you find that the results are almost similar in arm A and arm B. So Piyush, does this bring any thoughts in mind? If both are similar, then why go for the stoppage after 4 months, and why give 5-fluorouracil? Any added benefit in these arms?
If we can go on the previous slide.
There you are.
So
basically, after 8 cycles of FOLFIRINOX, you introduce 5.
So the point is that 12 cycles of FOLFIRINOX are very difficult to tolerate. How many patients would take it? We eventually end up doing the practical arm B strategy, that we give around 6 to 8 cycles, and then we taper down our treatment to 5-fluorouracil. That is what, after 8 cycles, oxaliplatin toxicity, iron reticane, diarrhea, something props up. So I think so if the treatment arms are all
Yeah.
equal.
My thinking is that if both of them are the same, so your logic applies here, which you correctly said that you can decrease the neurotoxicity in these patients and get the same kind of benefit and probably sometimes prolong the benefit also. Mudashir, what do you feel?
Sir, I agree with Dr. Piyush, sir. We most of the times do the same. So 6 to 8 cycles followed by, say downgrading of the treatment.
So, Bharat, if I were to ask you here, would you re-challenge or would you switch? What would you do?
I agree with Piyush. Most of the patient we end up in not giving all the 12 cycles with all the 3 agents. So what I actually do in my practice, drop with one agent, and once we finish and patient progress in the future, switch to the other regimen and try to utilize the agent. Suppose I have dropped down irinotecan, I can utilize again in the third line, or maybe oxaliplatin I can combine with capacitab in the third line. So that is what real life
You
scenario.
talked of capecitabine. Between capecitabine and if it's a fit patient, if you have an option of FOLFIRINOX, and third option you have gemcitabine, because all these three have phase 2 trials to show that they have benefit. For example, if you give gem-nab-paclitaxel and follow it up with gemcitabine, do you think which one would be the best alternative to follow?
So there is no actual evidence to say which is the best to take it off and utilize. It's our individual experience, and then we decide whichever to take it, and based on the toxicities also sometimes. So
And
that is what
Yeah.
Dr. Vineet.
Yeah,
see, yes, the intravenous chemotherapy is 12 to 8 cycles. Is that what we give, provided the patient is fit? And after that, I think all of our patients will come to a thought process: can we do something without chemotherapy? Or can we have something oral where capecitabine comes into, and we adjust the dose? Not that we get the full dose. It can be a very good maintenance, and patients will also agree to it. And there is also some data of allortinib to be added in these pancreatic cancers in this scenario. Continue oral. My practice, I will continue oral if a patient wants to opt it.
So, Anita, how many patients do you continue allortinib as maintenance?
Not much. There's not data much, but I have 2 patients. It's almost 28 cycles going on. 28 months cycle means 28 months. Capecitabine allortinib with a metastatic disease. We gave gem-paclitaxel. He's elderly. We gave around 8 cycles. After that, he said, I don't want to come to hospital. Give me something oral. Son also wanted oral. 28 cycles going on now.
Yeah, there
Once in a year.
Small niche studies which show that if you give allortinib, then it might, it basically depends upon the onco driver. If you have the EGFR as onco driver, definitely you get a fantastic result. We had it in one young patient who was not fit for anything and he was bleeding like mad. We gave him allortinib just as a last resort, and he lived for 9 months, quality life. So I think we'll switch over here. We'll come to second line therapy. Shruti, how many first line phase 3 trial patients are eligible for second line treatment? Now, this is this I'm quoting these are the figures, at least 40 to 50%. But in your actual practice, how many patients do you see who cross over to the second line?
Sir, in the real life situation or real world situation, I would say yes, around, 50% or less, not more than that. Yeah.
Bharat, what is your opinion? You mentioned about continuation of therapy. You said we should have one after the other in tandem, and you should plan it in such a way so that you get expanded disease-free survival. So what in your practice is the number of patients who are eligible for second line? Same 50%?
So it all depends upon how fit is the patient in the front. So if I look at a very fit patient, we have more than 50%.
I mean, but, across the board.
Across the board, it is less than 50%, sir.
Less than 50%.
Because,
So Mudashir, Piyush, any new percentages, or is it the same with you?
Quite similar, sir. Probably slightly lesser one.
So I agree. I agree with the same figure.
Sir, can I make a point? Viraj here, sir.
Yeah, Viraj, please.
So what I have experienced is in patients whom I start with FOLFIRINOX, they often end up getting a second line gem based treatment. But patients who might start gem-based treatment because they were not so fit, they hardly end up getting FOLFIRINOX subsequently. So is it true with all the panelists?
We
Yes,
can
sir.
take a call. Piyush,
Yes, sir.
start with you.
Yeah, so that was a fitter patient, as Bharat already pointed that a fitter patient, you start FOLFIRINOX and probably the PS would deteriorate gradually. But for a patient where you already chose nab-paclitaxel gemcitabine because of your PS, rather a PS2, then probably chances are lesser.
Shruti, you were saying something?
Yes, sir. Sorry, I spoke in between. Sir, I agree. That's why I would suggest that we should all, I mean, for the fit patients or fitter patients, we should err on the, I mean, side of trying a triplet, because like Dr. Viraj very rightly said, that once the disease progresses and you have been giving gem and the disease has progressed, at that point hardly any patient would be fitter for even a doublet or a triplet. So better to actually start on a modified triplet and come down maybe if the patient doesn't tolerate, rather than choosing the lighter therapy or the milder therapy,
Yeah,
because that would become a comfort zone for the doctor and the patient. So
that is what we have discussed. There were broad parameters which we have discussed: the general condition, performance status, the albumin status, the LFT status, what is the status of the stent, whether they are stentable patients or is it parenchymal jaundice, the comorbidities which are there, and of course the mutational status, whether the patients have BRCA1 or 2, because that can be very nicely included into the treatment. So we agree that about 40 to 50% of patients switch over. So now let us come again to Mudashir. What would be the optimum therapeutic sequence? Quickly, if you can tell me, because I just have 3 minutes left.
Sir, I think the fitter patients, the choice number 1, FOLFIRINOX in the first, modified FOLFIRINOX in the first line, and then gemcitabine based therapy in the second line.
Anita, anything? Or let us go to Piyush.
Yes, I agree with this, sir.
Bharat, anything?
No, same, sir.
Same. So I think we broadly agree that those patients who are fit, give them the best choice even in the second line, so that we can get the maximum out of that. And
Dr. Vineet.
Yeah, Anita, I lost you in between. Yeah, please.
Yeah. So a couple of things for at the second line. I think some more drugs can be also added into that, like capecitabine, and the single agent drugs can be also used.
Have you
not.
Used irinotecan, this Nile-Eri, any patients?
Yeah. Just simple, plain irinotecan, just plain 5 if you leucovorin I've used. That gives you another 6 months, 9 months down the lane. Again, give a single agent and continue. In second line, FOLFIRINOX may not be a choice for many of us. Second line will not be able to give, they become too sick for it. But what you rightly told, single agent, we can continue. Even capecitabine you can put. Tenofovir uracil is also there as an oral drug in the guidelines in a pancreatic cancer, metronomic. So these are some of the choices in these patients.
Right. So this was the meta-analysis on second line therapy, and there was just a modest improvement in progression-free survival and none for the overall survival in patients in which fluoropyrimidines and oxaliplatin was used. And so I think again here, the preservation of the quality of life is the most important thing. Wherever you find that there is a decrement, that is the time where you switch from doublets to singlets, and accordingly you proceed in these patients. So I think we are reaching the end of the time limit. So gemcitabine has been the global standard of care for nearly 2 decades, and FOLFIRINOX is the one which is used. Modified FOLFIRINOX, all of us agree that is the best, which is used in the best patients, that is the most fit patients. Wherever the fitness is the criteria or the comorbidities are the criteria, you choose accordingly. You can switch over from after 4 cycles of FOLFIRINOX to a lower version, that is 5-fluorouracil, continue if peripheral neuropathy is a problem, and again you switch back again. We have discussed which are the patients in which we can switch back. PARPI has really revolutionized the treatment, as Viraj also mentioned in his talk, and universally it should be done, germline should be done, and if possible you can do the tumor BRCA testing also. There is a rationale for doing HRR in pancreas because you might miss another 25 to 30% of patients. And since I told that this is not a relatively immunogenic tumor, then you got to combine 2 or 3 types of treatments to get the best benefit and increase the survival outcomes for the advanced pancreatic cancer. So I think I thank all my esteemed panelists, and I close the session, and back to you, Viraj. Thank you.
So
Thank you, sir. Thank you.
I would want the panel to wait because I have a couple of questions which I wanted answers for. So, sir, with your permission, Vineet, sir, can I ask?
Yeah, sure.
Right. So 2 questions is, let's say if we panel is selecting gemcitabine nab-paclitaxel. First is, what's the dose of nab-paclitaxel we are all using? And second is, what is the schedule we are all using? Is it 1-8-15 or we have moved to day 1, day 15? Mudassar, we'll start from you.
I use Dr. Viraj, thanks. So I use day 1, 8-15 if the patient tolerates. So in the first cycle, during the first cycle, I feel get a feel of that. So, and then I may kind of modify it. But I use day 1, 8-15 mostly.
So for 6 months, you would continue 1-8-15, 1-8-15, 1-8-15.
It is almost impossible to do that, but yeah, I can sometimes I make it like 2 weekly later on.
2 weekly. So since now we have 2 centers coming up with the data that 2 weekly is not inferior to weekly, that's why I was bringing up. Dr. Yes, madam.
Yeah, Dr. Viraj, I agree with you. I have started doing 2 weekly because of logistics from a long time. Okay, these advanced cancers, difficult to call them weekly. We put a central line once in 2 weeks, nab-paclitaxel, and gemcitabine, we give 1,400 milligrams start dose, nab, depending upon the patient's body, 100 or 200, 150 to 200. That's what we give.
Nab-pacli dose?
100 milligram per square meter.
Per square meter or flat dosing?
Flat dose depends upon the square meter. A healthy individual, we can go up to 2. And also we ask about the neuropathy, diabetic neuropathy, and take a decision. But this is how I'm doing, because that's logistically possible in an advanced cancer where we cannot tell them you come every day. And line is must, definitely. All these pancreatic cancer, put a line, central line has to be in place.
You have a port?
Yeah, if it is 2 weekly, or if you're giving day 15, you need a port. Nothing you cannot do. How can you prick the patient every time? You'll get on again. We have to convince that this is your protocol. The treatment is going to be a long treatment. You need a line. PICC will get infected. Difficult to manage in a medical college setting. If finance is not an issue, logistics are in place, port catheter, and you are comfortable, patient is also comfortable.
So Dr. Piyush, how many your patients of GemNab have a port, and is it weekly or 2 weekly?
It's weekly, Viraj, for now. And
all the cycles?
At least up to 4 cycles, and thereafter probably there is a staggering. But the intent is not 2 weekly. I mean, sometimes it's at 10th day as well. So regarding the PIC line, I think so most of the times it is a peripheral line, sometimes parenteral nutrition, then central line.
PP Sahu sir has said 75% no ports. I agree. Same is my practice.
Most of our patients have PIC lines. Almost 80% have PIC lines, and we are very happy with that because we have a very well-oiled machinery. We have a proper PIC line room where at the inception, all the instructions are given. And we have a data also to suggest that the PIC line infection is about 70%. 7%, not 70%, 7%, and ports is about 10%. We have collected over 2 years. I wish I could present it here.
Great.
Yeah, as Sahu says, if used with care, definitely. There are times we can where we have used it till 9 months, but generally we use it till about 6 months.
Sir, I also mostly prefer PICC lines, and I have kind of used in few patients up to 1 year. So when it got, really, it was like the outer part was really gone. Then only I actually took it out. So.
Okay. Thank you so much. Thank you, Vineet, sir.
Thank you.
Thank you. Thank you, Dr. Viraj. Thank you, sir.